So chapter 9, team approach to healthcare. BLS complements ALS. So if there is no BLS, the ALS will be terrible. If there is no ALS, the BLS won't make much of a difference. So these two things are important to the patient's prognosis being good or bad. Neither is more important than the other. So basic skills or BLS skills is just as important as ALS skills. National EMS Education Standard Competencies for this chapter applies fundamental knowledge of patient safety to the provision of emergency care. Applies fundamental knowledge of transferring patient care, how to interact within the team structure, and team communication and dynamics. Introduction. You are a critical member of an emergency healthcare team. A key goal of EMS Agenda for 2050 is EMS systems that are inherently safe, which minimize exposure to injury, infections, illness, or stress. A culture of safety is encouraged, and just culture, fear culture, is encouraged. An era of team healthcare. Community paramedicine and mobile integrated healthcare teams is the future. And these are healthcare providers that will be responsible. Well, I don't want to say responsible, but their function is based on quick identification of illnesses and injury, treating acute issues or emergency issues, and continuing care from a community level. And of course, prevention will be a big part of that. But this is a way forward where they are bringing healthcare to the community instead of the person have to be at a clinic or a hospital. So this will reduce overcrowding. And it is now a specialty for paramedics. So once persons get to paramedic, there are, I believe, 3 options outside of beyond the paramedic. You have community paramedicine, you have critical care transport paramedics, and you have tactical paramedics. And there are certifications that can be acquired for all 3. The structure and effectiveness of emergency healthcare teams differ from system to system. So every system is going to be different, and how their structure is set up is going to be a little different. Now, types of teams. You have regular teams, which consist of EMTs. So EMTs consistently interact with the same partner or team. That's a regular team. Not something that is encouraged, but it happens. You have temporary teams, which is what should happen. You should rotate. Shouldn't be stuck with one person. There should be some rotation. You need to interact with other team members. That's important. Special teams. Then you have your special teams. This can be a fire team, can be a rescue, hazardous material or hazmat team, tactical EMS team, special event EMS team, EMS bike team, which is common in the UK. So they have bike medics in the UK, and I strongly believe the UK have one of the best EMS systems in the world. In-hospital patient care technicians and mobile integrated health care technicians. Now, group versus teams. A group consists of individual healthcare providers working independently to help the patient. So that's a group. Each healthcare provider within the group has a specific task that they carry out. It can be specific to triage, it can be specific to treatment, it can be specific to transport. So a group member is responsible for triage, one for treatment, one for transport. Think of it that way. That's a group. A team now. A team consists of a group of healthcare providers who are assigned specific roles and are working interdependently in a coordinated manner under a designated leader. So this is a team that is responsible. So let's say this is a team that is responsible for treatment, assessment and treatment, but there are more than one person in that team and there is a leader. So roles are assigned by the leader and the leader doesn't interfere with the task that is assigned unless there is complication. So if the leader say, position the airway, insert a OPA, start back the patient, and the task is not being done correctly, then the leader has to take over that task. Now, 5 essential elements of a group. There must be a common goal, an image of themselves as a group, so you have to see yourself as a group, a sense of continuity of the group, a set of shared values, different roles within the group. These are essential elements. Now you have dependent, independent, and interdependent groups. The dependent group, each individual is told what to do and often how to do it by his or her supervisor or group leader. That is not the type of team I want or I would prefer. So I don't want a team where if I delegate a task, I have to also explain to my team member how to do that task correctly. That's time consuming. So that's like you're working with somebody who has no training or limited training. Let me not say no training, limited training. That's time consuming. Independent groups. Now with your independent groups, each individual is responsible for his or her own area. So that would be like you have the ER doctor, you have the ER nurse, you have the respiratory therapist, you have the ultrasound technician. Each of them are responsible for their own area of expertise. Interdependent groups now. Everyone works together with shared responsibilities, accountability, and a common goal. That is the ideal group for EMS response. You want an interdependent group working together. We have shared responsibilities, we have accountability, and we have a common goal. Now, effective team performance will be dependent on a shared goal, clear roles and responsibilities. So your role must be very clear and you need to know what your responsibilities are. You need to be diverse and competent skill set. So you must have a diverse skill set and you must be competent in the skill. Effective collaboration and communication, supportive and coordinated leadership. And as I say, I do not want, and I don't think any organization is going to want a team that they have to be telling them every single thing that they need to do and how to do it. So there is going to be time where it is necessary for the leader to take control of the call. And for me, it's going to be when it's a critical patient. So when it's a critical patient, I will take control, guide them accordingly. But my practice is if we go on a call and I think the patient is not unstable, the EMT that I'm working with is going to lead that assessment. I'm not going to lead the assessment. So I'm there. If I need to step in and guide you, I will, but I'm going to allow you to lead that call, and you tell me what to do and I'll do it. If it's a critical call, I'll take over once it's outside your scope of practice. But the EMT needs that. So a young EMT that's coming into a service, you can't just have them working and telling them. They're going to become dependent on you telling them every time what they need to do, right? Right now I have a young one working with. I'm still giving him instructions in the field because I think he needs about maybe 3 months of working before I can give him a patient to lead. But it's gonna happen. It is gonna happen. And if he's not able to deliver, then he would not be suitable for our organization. Right? So that's important. That's how you build your team members. Now, communication and team dynamics fostered from crew resource management and team situational awareness. So, crew resource management recommends the PACE mnemonic probe. So, look for what the issue is. If there's an issue, then everybody within the team need to be aware of that issue. Think about what are the challenges to address the problem and whether or not it is an emergency situation. So is it an emergency situation and requires an emergency response? Then all of these things need to be considered. Now, transfer of patient care. Transfers introduce the possibility of patient care errors, most definitely. General guidelines for a smooth transfer, uninterrupted critical care, minimal interference, respectful interaction. Always be respectful, always be professional. Deliver your report. So always give a verbal report of your patient before you hand over. Common priorities, common language or system. And sometime when you hand over and you have given your final set of vital signs, look at what their initial vital signs are, right? So upon leaving, after the patient was transferred to the definitive care, the initial vital signs were XYZ. That's important. A common language or understanding of the system is important. And that's a big issue in Jamaica because a lot of the allied health care providers and in-hospital healthcare providers do not understand or function, and they don't understand why it is that we do certain things a particular way, and that can cause some issues because I might bring in a patient that I think needs a certain amount of oxygen, and a nurse, because she doesn't understand how EMS response work and what guides the treatment, she might say to me, why am I giving the patient so much oxygen? Because it's not within their training to give oxygen beyond a certain level. So that can cause issues, and that's why we need medical direction. The purpose of a medical direction is to fill that gap. So the medical director is the liaison between all of these healthcare professionals. And if there is concern about the way that we do things, the medical director clears that up. This is why they're doing what they're doing, right? And the truth is, pre-hospital emergency care is way, way different from the in-hospital. It's not the same thing, right? So I cannot take a doctor out of the hospital and put them on a field response and expect that they are going to be performing as they should, because they were not trained that way. They were not trained that way. So it's two different elements, two different professions. And again, neither is more important than the other. So what the doctor does is not more important than what a nurse does. And what a nurse does is not more important than what an EMS responder do. All of these functions are necessary. So they must be cohesive for the patient to get the best response possible. None is better than the other, and that's a big issue in Jamaica. Now, BLS and ALS providers working together. BLS and ALS care cannot exist without each other. I mentioned this earlier. So doesn't matter how skilled you are, how much qualifications you have acquired after your EMT training, right? Even if I get to the level of a surgeon, or even if you get to the level of a surgeon, if a patient codes in surgery, you have to start with BLS stuff first. You have to start with the BLS stuff while you're getting the ALS stuff ready, because ALS, some ALS procedures take time. You have to select the appropriate advanced airway. You may have to establish IV access. You may have to get the patient on a cardiac monitor. You may have to set up medication. These things take time. So while you're doing all of that, there needs to be good BLS. If the BLS is not good, the ALS won't matter. So they are both important. And let me go even further, because it's like a trend. The higher we go in our training, the less we think of the levels below our training. I will always be an EMT. I was an EMT before I became a paramedic. And I'll always be a paramedic, even though I'm beyond the paramedic level. So there are certain things that are required at each level and will be important to the patient. So a simple first aider is valuable to you. And I'll give you an example of simple first aid being valuable to me. So the same patient that I was telling you about that accidentally shot himself in his leg, his quick thinking actually prevented him from going into shock. And what he did was a first aid procedure, whether or not he had proper training, but what he did was a first aid procedure. He immediately tied something around his leg. He immediately did that. So when I went out there to assess him, he did not lose a lot of blood at that point. Didn't have a lot of blood loss. So his first aid played a significant role in me being able to control his bleeding, because with his effort, his ABCs were stable. So when I got there, his ABCs were not compromised. So I could focus on the bleeding control. If his ABCs were compromised, I would have a tough time, because I would now have to think about airway management and bleeding control. And remember, I am the only person there that's trained as a responder. The person that is coming with the ambulance can only assist me to move the patient and do a bare minimum as it relates to first aid stuff. So even a first aider is valuable to you as a responder. So when somebody calls for EMS response, the instructions that a dispatcher give that person, if they are able to do it well, it will aid significantly in the patient's prognosis, will be valuable to that patient survival, because when we get there, we would not need to do that. They have done the bare minimum. All we have to do is sustain that. And it works the same way for BLS. So if the BLS is effective, when the ALS provider comes, the ALS provider doesn't need to repeat the BLS. They just need to start advanced care. And if the advanced care is good, when the patient gets to the hospital, the doctors and nurses don't need to do it. So if I start an IV for the patient and I have already given a required medication, the doctor doesn't need to do that. They don't need to start the IV in the ER because I already did. And sometimes it's 2 IVs we come in with a patient with. So all of these levels are important. None is better than the other. None is better than the other. And we need to get rid of that way of thinking in Jamaica. It's a big issue in Jamaica. Status is so important to a lot of people, and status is not important. Your work, the level of your work, the quality of your work is more important than a title. So BLS efforts must continue throughout the continuum of care. And that's why an ALS is going to need solid EMTs. What may be a paramedic only skill in your EMS system may be a common for an EMT to perform in another. When I was working in Texas, the ALS response or the ALS unit had one paramedic, one EMT, and the EMT that I was working with could start line, he could start IVs. And one of the things that we used to do is, if I am looking for an access on the right, while I'm looking for an access on the right, he's looking for one on the left. And if he finds a good one and can get it in, I allow him to do that, right? So some services make adjustments for that because it's expensive to have 2 paramedics on a unit. Now, assisting with ALS skills. Assisting follows a 4-step process: patient preparation, equipment, performing the procedure, and continuing care. So we need to be prepared to deal with any type of emergency. We must have the appropriate equipment required based on the patient presentation. We must be comfortable with the procedure that is required for the patient, and we must be able to sustain the care that we're providing. Critical thinking and decision making in EMS, very important aspect of EMS. Effective decisions are based on sound, up-to-date knowledge. Information provided by the patient history, physical examination. You see which one they put first? Sound, up-to-date knowledge. The key word is up-to-date knowledge. Very important, because there are persons who their knowledge is not up to date and they're giving instructions, especially in our little island of Jamaica, and that's very concerning to me. So the knowledge must be there, the understanding must be there. And I've even had a situation where one of the EMTs that I recently trained, he was asked a question and he was answering the question appropriately. So his response was appropriate. And the person is telling him to do something that is outdated because they don't have up-to-date knowledge. And what I said to that EMT is that when you work in an organization, any organization, and whether it's a EMS response system or you're working in the hospital setting, or you bring a patient to the hospital and somebody's asking you not to do something or why you did this, and it's within your scope of practice, or telling you to do something a particular way, whatever they are telling you to do, there must be evidence, research evidence to support it. So if somebody is telling me to assess a patient a particular way based on the way I was trained, based on the current standard, they have to show me the research to support that. Where can I find that information? Because I can pull up the information to show you now that what I did is the required standard. And that's me. I've always been that way. You can't tell me to do something a particular way if you cannot support it with evidence. So you can't tell me that I'm doing something wrong if this is how I was trained. You have to show me the evidence to prove. If you can show me the evidence, I will accept that I am doing it wrong. But if you cannot, I will do it the way I was taught. And that's what I said to the EMT. There must be evidence, because he felt bad, he felt embarrassed. They were laughing at him, and he was telling them the correct thing. We can't have that in our EMS response in Jamaica, right? We cannot be telling EMTs to do something that has been outdated for over 5 years, more than 5 years now, that has been changed in EMS. That's ridiculous. But I digress. So, sound up-to-date knowledge, information provided by the patient, very important. So you need to pay attention to the information that you're getting from a patient, whether the patient is verbally telling you, or it's based on the physical findings and presentation. Consider the history and your findings based on a physical examination. That's what guides critical thinking. Now, stages of the decision-making process. You have the pre-arrival stage. So when you're going to a scene, you start to think about what it is that you need to do, right? And I start to think about my primary assessment. What do I need to do in my primary? I'm gonna need to introduce myself, find out the name of the patient, find out what's wrong with the patient, assess airway, breathing, and circulation. Based on any issues, I'll have to manage that. So I start to think that way in my head. If it's a trauma, I start to think about, okay, am I going to need bleeding control like the patient recently, right? Where he got shot, did the bullet come out? Did it catch a soft tissue? Did it catch a bone? Did it catch an artery? Right? Is his ABCs compromised? Is he showing signs of shock? So these are things that I have to think about. If it's a call involving a fall, okay, gonna need to incorporate spinal motion restriction. Gonna need a KED. Gonna need a KED to move this patient. Need to be thinking about injuries to the extremities. How can I stabilize these injuries? Will they be a priority? Things like that need to be in your thought process. When you arrive, then this is where you're gonna actually see what's wrong, and you make adjustments accordingly. You have to also think about and manage what occurs during the call. So are there any changes? Are these good or bad changes? Do you need to make any adjustments? After the call, reflect. I always reflect. So after you complete a call, go back to your protocols. Look at your protocols. Think about the call. Is there anything I could do better? Is there anything that I need to work on? How could I have dealt with this situation better? What adjustments I need to make for myself and my team? All of these things are important to developing critical thinking skills. Now, decision traps, bias. anchoring, and overconfidence. So don't think that because you have dealt with 50 or over 50 chest pain patient, this one is going to be the same as the others. It doesn't work like that in EMS. Every patient is going to be different. Don't be overconfident. You're always a student. It doesn't matter how much knowledge or skills or experience you acquire. You will always be a student. There is always something for you to learn. Every patient is going to be different. So don't develop any biases. And anchoring is a type of bias, but it's based on a specific perception in your mind. And that would bring us, no, we're not at the end of the chapter yet. All right, troubleshooting team conflicts. Things to note. The patient comes first. So act in the patient's best interest, act in good faith, do no further harm to your patient. Do not quarrel over your patient. Never ever do that. That's very unprofessional, right? If you observe that your partner is doing something, give them something else to do. If they're doing something and it's not being done correctly, give them something else to focus on and take over that task. Keep your cool. When the call is finished, you can have that discussion, right? I see that you were struggling with this particular skill. What happened? Let's discuss it. Let's see how we can make this better next time we go out there. Notice I said we, I didn't say let's see how you can improve next time. Let's see how we can make this work better next time. All right, we may have to do some practice. We may have to do some practice with that specifically because it's the first situation that we're coming across. It's teamwork. Keep your cool, right? So even if it seems like things are not going accordingly, keep your cool. I've gone on unseen and need to do a GMR for a patient, and when I check the machine, no battery, because I thought my partner checked the machine, no battery, but I played it off. Nobody knew unseen that I couldn't get a GMR reading. Not a soul knew. I just played it off, did what I needed to do, and we had a discussion. And I didn't get a GMR for that patient until we reached the hospital. Right? So I played it off. Remain calm. Try to remain calm. Separate the person from the issue. Now, there are some calls that and this is something that I would do with my partner. So if you know that it's a particular call that you might have some trouble with, let your partner lead. Let your partner lead that call and choose your battles. Choose your battles wisely. You can work with someone that you don't like and still get the task done properly. So I have worked with person that we don't really get along very well, but when it comes to patient care, we do what is required. We do what is required. And are you here clearly at this point? I think my connection dropped. Okay. All right. Right. So you will have team members that you don't get along with very well. It doesn't mean that you can't do what is required for the patient. And it's very important that you're able to take criticism. Some persons get way too sensitive, and EMS is not a place for sensitivity. You cannot wear your emotions on your sleeve. And our tendency is to get defensive. So when somebody points out a mistake to us, we start to justify. You know, the reason for that was this. Just think about what they're saying, right? Process it. Did I really do this as how I should? You know, they are right. How can I make adjustments? Right? So we will make mistakes. It's a part of the game. But what is important is, do you acknowledge that it is something that you did not do or failed to do? And you are willing to make the adjustments? Or are you going to say, you know, sir, because of this, why that mistake here occur? And really, my fault, you know, is because I didn't have that. So like the glucometer situation, should I blame my partner for it? No, I should have double checked. I was the senior person. So it's really me for a check. So I made a mistake. I'm not gonna blame my partner for that. We had a discussion. You know, I allowed you to check the jump bag, and um, when we responded for that particular call, I realized that the glucometer machine didn't have a battery, so you probably missed that. But if I give it to do again, just make sure that you check that. I will make sure it doesn't happen again. Don't worry too much about that. We still did what we needed to do for the patient, right? But just make sure that if you're checking it in the future, you cover that. And I'll ensure that I double check certain things as well going forward. All right. So let's keep that in mind and go forward. That's how that's how teamwork is done. And that would bring us to the end of this chapter.